And moving on to the next session, may I please invite onto the dais Mr. Pramod Gaur, the Vice President, TeleHealth, United Health Group of USA, to introduce the speakers of the next session. Ladies and gentlemen, put your hands together for Mr. Pramod Gaur.
Good afternoon. I would like to invite the other two panel members that are going to be speaking, and David will be joining us a little bit later. So is the other the two speakers who are.
Ladies and gentlemen, I request the panelists of the next session to please come up on the dais. May I invite Air Marshal Dipankar Ganguly, the Director of General Medical Services. Sir, could you please come onto the dais? And also, Mr. Sid Ahuja, the Vice President of JV Alcatel-Lucent Ventures, New Jersey, USA. My apologies. Our speaker is A. Commodore Dipankar Ganguly, the Director, General Medical Services. Thank you.
Okay. All right. So we know this is the last session before the valedictory session. So we want to make sure that we provide you the pertinent information, and we do have time to get our key message into what we are trying to do. In this session, we are looking at the different facets of eHealth, and first presentation, I'm just going to describe to you about cloud-based telehealth solution for large-scale adoption, and then we will introduce the other speakers. So what I want to cover in this presentation is to describe to you a little bit about the telehealth as a service that we are describing, and then talk about the United Health Group's our focus in modernizing the healthcare delivery solutions, walk you through some of the examples, and then finish up with the business and economic case for large-scale adoption, in this case, the Diabetes Prevention and Control Program. So what is the telehealth as a service? Telehealth or telemedicine in the last 10 years has been really focused in hardware and software vendors who are developing innovative solutions, and then is being sold or partnered with the users. Since most of the time the solutions we are trying to introduce are new, the interaction between the hardware software developer and the service, meaning the healthcare application, has been hindered because it's very difficult sometimes even to imagine what are we trying to introduce. And so the thinking is that if you can combine, doesn't have to be one organization, but it's a combined effort where you have hardware, software, and service, and your measure or metric of success is the outcome, not how good your software is or how good is your call center is, but the combined effort to see the outcome. So the way the definition we have done very broadly, defining It's the ability to allow between the patient and the provider and easy and quickly connect them using ICT via information communication technology from anywhere, anytime to provide the better outcome. Again, the focus is on outcome. And we also start to look at, as a continuum of care, is that the individual at different time, their needs are either wellness and prevention to chronic disease management, behavioral health, acute care, post-acute, and aging. So same individual over time would have need in different areas, or if a family member, the family may have some other members who are at different stages. So in order for a sustainable solution, one has to address all the aspect of continuum of care. And in the past, the solutions were more trying to prove the concept, the small pilots, and trying to show for any particular areas. And now what we're saying is if we're going to be able to scale and sustain, it has to look at the holistically the person. And also, we are saying who are the key stakeholder. Too often we are looking at either the technology, how easy is by the patient to use it. We're discussing mobile phone, almost 800 million mobile phone in India and growing very rapidly. But that's the one direction we're looking at the person. But in order to look at the full outcome, one also has to look at this amount of information generated by a mobile phone, what's the resources needed on the provider side, whether it's a physician or the call center or the nurses, and how is their workflow, how is that fits into it. Similarly, we also have to pay attention on the caregivers and the community members. They're looking at, can this information help me, give me peace of mind, reduce the stress? And of course, the payer, whether it be a government, could be a insurance company or self-pay, they're looking at, is it affordable? But more importantly, is it really improving the quality of health care, or this is an extra incremental expenses? So that's the other part. We are saying any sustainable program, one has to look at all key stakeholders and address, is it going to meet their need? So using the cloud-based flexible infrastructure, we are now able to look at these four key stakeholders for any particular program. And so from the patient to the caregivers, the payer and provider, and what our solutions are looking at, we're calling it cloud-based services, is to simplify and allow to look at throughout the continuum of depending on what the person's needs are. And so we have the security, we have the infrastructure, simplicity for connectivity, and also the ability to provide the metering, so that only, since you are offering as a service, you only pay what are you using it. So that's the way we are trying to architect the solution is based on what is needed and what stage of the care is needed and adjust accordingly. So again, this picture is showing you the difference, how it works. On the very left is the medical devices. In this picture, we're showing a blood pressure cuff, oftentimes wirelessly using Bluetooth and other. It takes the reading and transfer to a device aggregator. Could be a mobile phone or tablet PC or a dedicated device aggregator box. That device then transmit that information via either cellular, Wi-Fi, DSL, and other communication ways to a central database where it's get authenticated and is stored for future use. So this is what's so-called store and forward technology. So this is a very traditionally, that's where it is stopped. And what we are saying in a telehealth as a service is what you're seeing on the right side. We're saying not only do we collect and transmit, but then how do we take the action? And that's the part we are in task we are adding as part of the solution. So a little bit about United Health Group. It's a Fortune 25 US-based company focused in health and well-being. And we have two major group of activities. On the left is the health benefit on the insurance part of the business, where we have about 75 million Americans, 1 in 6 is insured, and they are in the category whether they are commercially, meaning working for the companies who are providing insurance, individual policies, state government funded or federal funded, or the U.S. military. Those are the different members make up. On the health services side, we are able to take health information, analytic exchange, and integrated pharmacy management, clinical and disease management, and also we are able to incorporate revenue cycle management and administrative services. So together, we are able to have a network of over 650,000 physicians, 5,000 hospitals, and we are able to provide our services to serve over 75 million patients. Our focus on modernizing the healthcare delivery is to focus on the patient. And today, as other speakers also talked about, is the point-to-point, very fragmented healthcare system. Patient, if they has individual interaction, the data is stored there, and there's very little interoperability between the one service to the other. And we need to if we are going to provide patient-centric, be able to electronically capture and share the information. What we have done, these different stages of continuum care I talked about and basically grouped into 3 areas. Number 1, we want to help people stay healthy. So this is where the community and population-based wellness screening, prevention, all those activities are designed to help people stay healthy. Once people get sick, we want to help in early diagnosing and as well as the disease management to help them get healthy sooner. So that's the second objective, is if they get sick, we want to help them get healthier sooner. And then the third focus is those individuals who do have chronic disease, we want to help them live with that illness and still live as productive life they can. So our telemedicine model is looking at connected care, trying to connect person-centric solution we talked about, whether they are at home, whether they're at place of work, at rural setting, in community health centers. And so we are looking at connecting individual to the provider regardless of the location they are. And we have solutions and application in all different setup. There are a couple of them I'm going to give you example. So our healthcare professional on demand solution is basically showing traditional telemedicine, but now we are using cloud-based thin cloud services, and we have all the essential components to provide this service. We have as I described, 75 million members, so the patients are there. We have the both doctors and hospital networks we have data and analytic information and the technology. So this is the part where we want to use this to focus with the outcome as a telehealth as a service rather than just providing the technology. We communicate to our members the way they want to hear and how often they want to hear. So all the way from web portal to a smartphone to a paper report to a call center. And again, interaction for individuals to receive their information. I want to give you a couple examples we have introduced. One is called Now Clinic, which is a PC-based solution where anytime, 24/7, a member, they need a consultation, they are able to get doctors, and they're able to have a video consultation or text message or a audio consultation as they wish. And in this program, they're also able to, the doctor is able to see the chart and the trending of the services. Another program, large-scale implementation, is for disease management. We have over 20,000 congestive heart failure patients upon discharge. They are given a weight scale and ability to transmit their information. We have a call center where a registered nurse is monitoring them, and as needed, the physician is notified and intervention is taken. So the last part I want to finish with this large-scale wellness and prevention program we just launched is diabetes. As you know, diabetes is a very rapidly growing concern, and in India also is a big concern. And there are two elements of diabetes program. One is the prevention for diabetes, where if the person in the U.S. last estimate was there are 57 million people are what considered pre-diabetic condition, and here the key element is to help change people their lifestyle. It can at least prolong or sometimes even reverse the conversion from pre-diabetic to diabetic. On the diabetes side, we have people with, oftentimes there's a type 2 diabetes, which is non-insulin dependent, and there we need to help people, again, monitor their blood sugar level, monitor their cholesterol and other precursor that leads to complication of the diabetes. So in this program, we have, as a covered benefit to the members in our program, we have partnered with two groups for the prevention. In the U.S., we have partnered with an organization called YMCA, where members signs up for the program, and they are able to work on a well-defined. This is the program was validated by Center of Disease Control, CDC program for following through and trying to focus on their prevention side. For those who have diabetes, we have partnered with different pharmacy organizations, and we are now working on a quarterly review with the pharmacists and trying to have their assessment and have once a quarter face-to-face discussion with the pharmacist and address the non-compliance, missed healthcare appointments and opportunities. So this is the program we are working with. So this is a program where it is covered, and the reason it's a covered insurance program is for the prevention side. 10% reduction in body weight can lead to almost 50% reduction in conversion from pre-diabetic to diabetic. So the statistics are very, very compelling, and it's quite doable if one can focus on behavioral change. So last thing, in summary, what we're trying to do for large-scale adoption is to create a health advisor or actionable solution, tie that with the technology. So in this case, we're talking about a health advisor can coordinate what's happening to the member, whether they are in the hospital or they're at home or they're going to see their doctors. So it's a person-centric solution, but then It's being monitored through a service center, and then it can aggregate the data based on the provider. If it's a physician, it can aggregate all the patients that a physician's seeing. If it's a hospital system, an employer, we can aggregate that data based on the provider for the service. So with that, I'm going to stop here and let's see. Okay, and then you want to change this? So I would like to now ask our next speaker, Air Commander Mr. M.K. Bedi, to give the talk. Thank you.
A very good afternoon to you, ladies and gentlemen. At the outset, I wish to thank the organizers for giving me this opportunity to put forward the initiative by the Air Force in the field of ICT in healthcare. Our DGMS here, who was initially supposed to give this talk, is unavailable due to some urgent commitments, so I shall be covering the talk. I begin by quoting from our former President, Dr. APJ Abdul Kalam. Revolution in communication technology needs to be harnessed to deliver healthcare services in rural India. The need is to create a healthcare system that is both affordable and effective. I'm sure the speakers before us in the last 48 hours of deliberations have covered enough of it. I will restrict my talk to the Air Force setup and the initiatives that we've taken. The basic unit of the Air Force is an independent Air Force station spread across the expanse of the country. The peculiarity are, it could be a flying unit with larger units of administrative services, logistic services, and medical services. They are generally located at a distance from major cities, but they are self-contained. They have a mixed and constantly changing population due to the necessity of transfer of personnel from one station to the other. And in fact, they have to be prepared for war and disaster situations. The primary health care, it being far away from cities, is provided through the station medical center or the MI rooms as the case may be. It consists of a medical service, a dental chair or a center services, a station health organization for preventive and promotive health services. The SMCs provide routine and emergency diagnostic and curative services, preventive and promotive health services as I mentioned earlier, health education to the serving personnel, and aviation-related services, since aircrew form a major backbone of the service that is offered to the country. This is followed up by a robust secondary and tertiary healthcare armed forces hospitals, but these are generally located in towns and cities and not connected by data, WAN or LAN to the primary service care providers. However, what has changed now is we have a state-of-the-art, fully secure and reliable network and a gigabyte information grid. The facilities of this grid are an email, instant messaging, voice, data and video connectivity. All the software that I shall speak of presently and subsequently is based on the principle of central deployment. The IT projects that are in progress or have been installed are the Air Force Electronic Medical Records and Data Management System, the Health Information Card, the Hospital Information System for the hospitals, the software for for station medical centers, a software for the headquarters for collation of data, an interactive forum for serving personnel to address their queries, and a telemedicine facility which is in existence and we are upgrading it. As I said earlier, the software is on a central deployment on the Air Force net with the periphery in contact with it from the SMCs to the hospitals and the dental centers. This consists of a hard IT framework encompassing all the SMC, the hospital and the headquarters with seamless integration of data communication, voice and video to the center to the periphery. The Air Force Electronic Medical Records and Data Management System consists of the Medical Information Database, which is Oracle based. It has a document management software, also known as the ArcaDoc, and is deployed in our headquarters since 2004. The medical examination and board details of all personnel from enrollment to retirement are archived. This has been achieved by scanning of the previous documents and archiving them. Presently, all electronic data, medical data is electronic transmitted to the headquarters and stored in the MID. It has a facility for retrieval and search. This is a snapshot of the multiple search capability. We can do simultaneous search of the disability of disease groups, age, sex, categories, etc., so that we can have a trend analysis and future planning of medical services in the Air Force. This is a screenshot of the archival of the document that has been carried out. Due to ethical and legal issues, hard copies are still maintained, although all the hard copies have been scanned and are available at a click of the headquarters for analysis. The Air Force has embarked on a project of health information cards for the serving personnel. It is digitized, readable, editable health information that will integrate with the AFNet. At a later date, even the families of serving personnel will be included in this project. The HIC, as it known as a waterproof plastic contactless 32 kilobyte card, it has a snapshot of vital personal and health related information of the air warrior. It also has the last 5 visit data secured in it. It will pick up all the information from the electronic medical record system, and it can be read and written after biometric identification by the users. It has been developed on .NET and Oracle. As I said earlier, it's centrally deployed on the Air Force net and integrated with the other services that are being provided. Here's a look at some of the screenshots which will be available on the HIC. Here are the service personnel details, which are one-time entry only. The annual medical examination, the services follow a principle of promotive healthcare, wherein every serving personnel is examined once a year, and these are documented. So this is a record of the documentation of the medical examination. The medical board details, that is in case any person falls sick, he is examined by a board of medical officers, and this information is recorded for future use. The details of the OPD of the individual, as and when he reports. Details of hospitalization of the individual. Now we'll come to the hospital information system, which has been installed at the Command Hospital, Air Force Bangalore. It is developed on the Day2 technologies and is Oracle-based database, and it was a turnkey project. It is completely functional now. At present, it is standalone. However, these are the modules that are available on the health information system. They have been slightly tweaked to cater to the Air Force service needs in difference to the other civil hospital setups. You will notice that there are no business modules in this hospital information system. This hospital information system that was standalone will now be centrally deployed in the Air Force net, with user rights being provided to the other Air Force hospitals, and will be integrated with the other services which are provided through the AFNet. Also, a monitoring module has been added for the data analysis at the headquarters level. Most important, the station Medicare centers, which provide 90% of the services to the clientele, a software for that is being planned, aptly called the IF Mednet. It is outsourced since November 10. It is being developed on Day2 and Oracle technologies so that it is interoperable, and all users will require Air Force Net ID and a password for logging in. It is completely secure. It has been integrated, as I said, with the other software. The hardware required is, we have provided for at least 30 FNet ports at each station Medicare center for users. It will require desktop PCs, barcode scanners for the dispensary and pharmacy control, generators, webcams and printers. It is a user-friendly web app application. The administrator, local or central, defines the access privileges of each user, therefore making it more secure. It will provide for digitized reports and returns in the service format as is required, and also as a facility for online approval of medical examinations and boards. There is also a facility for providing of digital signatures and SMS alerts to the clients. It provides for data access across all medical establishments. It has telemedicine and teleradiology facilities with facility for medical equipment interfacing, biotelemetry from the air ambulance role, which the Air Force is planning to achieve, and also will act as a powerful search engine for data analysis. This is how the IF Mednet will function with a central database server, application servers, and all the peripheral SMCs attached to it. The modules of the Air Force Mednet, we have customized the existing HIS modules for use in the SMCs and have added a monitoring module at the headquarters level. A few screenshots of the IF Mednet. This is the main dashboard which includes all the modules. The patient registration, which I said earlier, is only one time. Each patient will be provided with a unique HIN and a barcode, which will be valid across all Air Force medical establishments across the country. And a photograph of the patient will be captured through a webcam with an option to create a visit through a swipe of the HIC card, which is being planned for personnel, which will be interoperable. A screenshot of the doctor's screen, which will provide for a patient's previous history at a click, and it has a symptom diagnosis and a treatment assist for the healthcare provider with a facility for online prescription and radiology/other investigation requests. The dispensary or the pharmacy control, it will have barcoding for the medical stores, online prescription and local purchase requests can be accessed. It will provide for online indenting and receipt actions, automated monthly maintenance figures created for based on actual consumption for planning of the medical stores, and the principle of distribution will be on the first expiry, first out basis. In addition, now we have developed an interactive forum for Air Force personnel, which is accessible to all serving personnel, and the queries are answered at the headquarters level. It is a platform for free, fruitful and frank interaction. This forum, in addition to having information on medical facilities, has a public and a private option where a query and a reply are visible to all, or an individual can assign a password to ensure confidentiality of his query, which is answered within 24 to 48 hours. Needless to say, the forum has been a huge success. This is a snapshot of the forum, where the public and private forum are encircled. The Air Force telemedicine project began in 2005 as a tri-service project in collaboration with ISRO. It provided for consultation between 5 primary healthcare services in the Air Force with tertiary care hospitals. However, there were issues with this telemedicine project because the physician as well as the patient had to be taken to a specific room, as it was through a VSAT link. It has now been discontinued because we have a better system available. The telemedicine on the AFNet will provide through desktop PCs, video phones and web cameras, It has communicative services, interface with biomedical equipment. It will provide for OPD consultation with specialist opinion on ECGs, radiological investigations, lab investigations, and also for dermatological consults. In addition, in an emergency, there can be a communication between casualty evacuation teams, SMCs, the primary care provider, and the secondary hospitals, or an ICU consult between a secondary and a tertiary care hospital for the benefit of the client. This is how we plan to have the telemedicine facility, right from the Casovac team to the Command Hospital Bangalore, which is a tertiary care provider having all the super specialities. In addition, we are now envisaging usage of a health presence, which is a desktop-based solution, easy to deploy. It's been provided with Cisco solutions, and we are in the process of evaluating it. Therefore, the Air Force in future will have a complete medical grid with interoperability complete between all the systems and software, and enabling HR, management of medical and paramedical staff, procurement of equipment and stores, using these data for organizing and planning issues, analysis of statistical reports, and providing for a research facility. I have finished. Thank you very much. If there are any questions, I'll be able to answer them at the end of the talk.
Thank you very much. Do you want to speak? You can? Okay. Well, David is here in the right time to talk about ehealth in South Asia, making it happen. David, we're running kind of short, so we're going only about 8 minutes, 10 minutes.
Please remove that question mark, India the leader.
I'm sorry?
No, Mr. David, I said India the leader. Please remove that question mark.
Oh, okay. Actually, I spoke here a year ago at the first conference, and I said then I thought India would be the leader in ehealth. It still isn't clear that it will be, but I think it will be. A couple of takeaways. We have these huge, intractable public health problems, and they're both in the developed and the developing world, and we've been talking about that quite a while. What we haven't talked enough about is the 2 billion people at the base of the pyramid, the 2 billion people who are not part of the formal economy. We can now talk about them because of the wireless explosion. And it really is about wireless, and it's not really about broadband. This conference has sounded at times a lot like a U.S. conference or a European conference where all the communications is assumed to happen on computers. If we're going to get to those 2 billion people, it's not about broadband, it's about wireless. Now, yes, eventually wireless will become broadband, but it's not today. I think, though, that there are enormous health and business opportunities if we can simply deploy ICT to record the continuum of care and then experiment on top of that. But we need to solve this problem. We need to talk about distributed health. We need to talk about a different paradigm of delivery. And a number of the speakers have talked about that, but an awful lot have talked about the opposite, which I'm going to call digital reinforcement of the current system. That will work nicely in hospitals, and it's really not going to work to get to the base of the pyramid. We're going to need a new system to do that. And we need to think about it as a system and think about it as an integrated approach from the top of the pyramid to the bottom of the pyramid, not individual shots. In order to do that, we're going to have to think about how to organize the ecosystem. Who's in the ecosystem, how they're in the ecosystem, and what the value chains are. Because there are, in fact, quite a lot of barriers to that question mark. There's a lack of high-level government understanding. Most of the high-level government understanding in this country and in my country about this field is about ehealth. It's about health records. It's about broadband networks. It's about linking all the hospitals together and sharing information. That's what ministers in this country talk about. That's what their equivalents in my country talk about. There is a real lack of understanding of what the value chain is, what the outcome analysis is from end to end. And except at the top of the pyramid, there's a real lack of understanding as yet as to what the business value chain is, how you can make money or save money doing this. And because of that, we're seeing a lack of integrated systems, and because of that, we're seeing a lack of focus on the common things we need to have an interoperable system. The United States is a perfect example of what not to do in this field, because we lack those shared capabilities and services that will allow us to move information around. But we're at a real inflection point, and you as a country are in a position where you can lead, or you can spend a huge amount of money following the model that we've set. So I obviously am encouraging not to do that, but it's not clear to me whether you can actually disruptively innovate within the traditional systems. The place we are in eHealth is way down on this stack, on this value stack. So we have a long way to go upward. We're way low on the innovation stack. We're innovating with devices and bits of software. We're not innovating with systems. We're not innovating with deliveries. If you want to innovate, though, Clayton Christensen has a book called The Innovator's Prescription. I strongly recommend reading at least the introduction in the first chapter. If you read that, you'll have a lot of fun things to say at your next party, but it also provides an analytical framework. And basically what it says is you cannot innovate by just having the innovation. The innovation has to have a business model, and it has to have an ecosystem. And you need a leader to put all of that together. So the real challenge is not what the technical innovation is. That's wireless and things delivered by wireless. It is the business model, as Charles Anthony was saying. But beyond that, it's what's the ecosystem to deliver those. Right now, we have this. We have a system which in your country, there are lots of the developing world, and a lot in my country as well, there are people who simply don't get care. And those that do get care go to some place to get it. And we have hospitals full of people who shouldn't be in the hospitals. Instead, we need an information pyramid. We need a knowledge pyramid. We can't, this one-to-one medicine is a doctor sitting with a human being, whether they're in your office or on a video screen, is not a model that's going to scale. It's a model we can't afford in the United States. It's a model you're going to find out you can't afford in India, and it certainly doesn't reach the bottom of the pyramid. Something like this is necessary. And I feel so strongly about it, I turned the pyramid on its side just to emphasize the point. But if you think about it, at one end you have hospitals, and medical centers and AIMS and the kinds of real knowledge bases. And then you have doctors, information centers, which can be call centers, or even better, look what business does. They have automated call centers where you don't have to have a human being at the end of it. Clinics is something that we haven't talked enough about. Small, frontline clinics to keep people out of hospitals wherever you have, and workers who are empowered by these new information systems, and then a much more knowledgeable public who's empowered by information systems. So we need to rethink the role of the frontline health worker. We can put power, training, and information in their hands. We need to rethink and put in place call centers and a whole variety of information services. At the high end, video consultation. At the low end, SMS querying. We're about to have a wave of medical devices. I'm very excited about what's possible here, being led by groups like Qualcomm, that Apollo's combining with. But the possibilities in this field, particularly when we come out with packages of these, not individual devices with individual software backends, but packages that allow, in effect, a primary care clinic to walk around in a bag into the villages. The clinic. I'm working with Health Points, Global Health Points, on a for-profit model that's turned the corner financially in Punjab, but developing clinics that are tied into this information stream. So there's a physical local point staffed by someone with some level of training, but not a doctor. We need to rethink the mechanism for connecting medical professionals to the public and for right skilling. A gentleman yesterday talked about labor productivity. The answer here is not creating more doctors. Doctors are expensive. The answer is not creating more nurses, although we need to do both of those. The answer is figuring out what roles can be played by other people and making sure that they have the procedures and protocols. Because most medicine, most health, can be systematized. And then have the doctors focus on the thing we need doctors to focus on. And we need to rethink hospitals. We need to be moving towards towards precision medicine, but India is blazing the way in terms of specified hospitals. You have LifeSpring for birthing and Aravind for eyes, but those kinds, so we don't have everybody showing up at a general purpose hospital. In order to do that, we need something like this. Now, I apologize to the IT people. This is what you get when you have a I'm going to make a big admission here. I'm a lawyer, okay? The good news is that I don't practice, so I've been on the wagon for 3 decades. But this is what you get when you have a lawyer do an IT diagram. But what we really need to have is a system of open architecture where the different components that are displayed here, in fact, kind of each word is a component, can interact with the other components in a standardized system. But as you look at this, you'll see that there's not one company that's going to offer this. At the bottom layer, that's the wireless carriers. The layer above that, I'm not sure who's going to provide the hosting. And then there are layers of software. So there are different players here offering different services that are going to have to interact. Which really leads to my major point, which is in order to figure this all out, we're going to have to get everybody around the table. All of these players are part of the ecosystem. We need to have them there and figure out what the interactions are going to be, who's going to play what role, if they need money for their business, how they're going to make money, if it's a government agency, how we're going to spend it. So I'll leave you with a couple of suggestions from an outsider who is falling in love with this country. Health is not just hospitals. I hope next year we're going to, at this wonderful conference is growing so well and so fast, that we'll have an equal focus as began today, an excellent presentation this morning on focusing on the person. So let's start with the person and think about what it's going to be. Hospitals are important, but they're only a piece of this broader equation. Anybody who's talking about doing this without electronic health records should be sent to the door and told to leave the conversation. We have to have electronic health records. But we shouldn't be trying to pick one. The UK tried to pick one with disastrous results. There should be picking a standard of how to communicate with them. India is blazing the way with its ID program. And I didn't hear anybody talk about it, but I wasn't here the whole time. But we really need to link to that. That's a huge asset we can take advantage of. Most importantly, we need to get all the right parties around the table, public and private, and use the power of the free market and supplement that. I mean, this issue of, well, they just want to make money, we need to get over it. The reason we can have the conversation is the wireless industry put wireless out all over India, and they didn't do it for free. They didn't do it for charity. So we need to take advantage of that. But in getting the people around the table, we need to design the ecosystem. What is it? Who does what? With the private parties, I would really encourage you, yes, you need to make money, but you're going to make a lot more money if you help create a broad ecosystem within which you can flourish. Go back to that original diagram. I would encourage you to form an information sharing and advocacy group, because one of the things we find around the world is nobody knows what the heck other people are doing. And then pick a couple of big projects and combine forces, even people who normally compete, combine so we can all learn how to do this. Thank you very much. I appreciate Apollo doing this. I appreciate seeing so many friends again and meeting new friends. This is really important work we're all gathered in, and I'm just delighted to be part of it. Thank you very much.
And now I would like to ask Mr. Sid Ahuja to give an overview summary for the meeting.
Thank you. Well, I can summarize. So there were 70 speakers. We have leaders, about 100 plus leaders in a variety of fields, all the way from politics to sciences to WHO and all the other organizations. And it's a lot to absorb. Let me start out by saying it was a great conference, and I think we should give Hearty thanks and credit to Ms. Sangeeta Reddy and Dr. Ganapathy for setting this up. I think I learned a lot, and I'm sure all of you enjoyed. How about a round of applause? Yeah. So in summary, I only have 3 minutes, but I can give you my point of view. I want to also thank Nikita, a young bright lady who took a lot of notes and gave me some pointers. I've lost that touch since I went to IIT. That was 40 years back. Anyway, the main essence of this is healthcare is not one issue, as David just pointed out. It's an ecosystem. There are many problems and needs to be attacked at many fronts. And over the 2 days, we have seen all the speakers speak about different issues. In general, the existing healthcare is a bi-party sort of issue. One is the healthcare that people don't even have it. So it's the how do we get healthcare to the poor, to the underserved and all that. And second is the people who have it, it's a big mess. So we need to figure out how to sort of solve that. The good news is, from all the things that we have discussed, that IT can really help. Okay? So I'm not going to advocate or go over the points that, again, but it is very clear that we are all making the efforts. All the efforts are actually, most of them are very valid efforts. There are attacks at different points of view, which we need. We need a multi-pronged attack. And as David mentioned again, it is in the end going to be solved by having a lot of team effort in this. Some of the major issues that were brought up were the issue of cost. So we need to be able to manage new business models and delivery of healthcare in a cheaper way. The issue of scale, which needs things like government support and the idea that we can deploy it at large scale for underserved people. The issue of education, which I think is a very, very big issue that was not, it was addressed for doctors and all, but not addressed for the patients. I think patient education is one of the biggest issues. Maybe it was addressed in the patient safety conference. But the patient safety issue relates to, again, the issue of education on both sides. The issue of transparency, again, empowering the patient, the idea of patient-centric. And I think these are actually very, very good themes. People are attacking that. In Hindi, there's a very famous saying which says, "Boon boon se sagar banta hai." For the Americans and the Western world, Rome was not built in a day. And we have to all lay the bricks out. And so I think you should give yourself a credit that you're all the small boon, which each one are. We are at the frontier of making this large sagar. I'm proud to be a part of that. And then thank you all for this. I think it's a great momentum. I don't think we don't understand the issues. We really need champions and teamwork. And I think this conference is a good sign of that start. Thank you all for having us here.
Dr. Pramod? Dr. Pramod, with your permission, can I just ask a question?
Yeah, please.
First of all, I must congratulate the Indian Air Force. I think you're doing a wonderful job. Just a small clarification. In case somebody gets transferred to another wing of the armed forces, say the Navy or the Army, does this unique identification number go on to the another wing of the armed force? Number one. Number two, when you become an ex-serviceman, could you enlighten us whether the same number will hold good even when he falls into the category of an ex-serviceman?
Actually, at the moment, this program or software is developed only for the Air Force, but there is a committee in place for making it tri-service, and there will also be a system wherein all three services will have a similar net which will be interconnected, so thereby ensuring interoperability between the three services. However, with the ECHS, it's not yet planned. Probably in the near future, we will do so.
This is not extended to the family of an Air Force?
We are in the process of extending it to the family. The SMC software, the IF MedNet, will be extended to the family. The card system is at present only for serving personnel. Later on, we will get the families in the loop also.
Thank you.
Thank you.
Ladies and gentlemen, if you have any more questions regarding the session, I think we have a question there.
My name is Manik. I'm CEO of Lifeline Hospital, Chennai. David mentioned that we should perhaps have standards for EMR, EHR. And over the past 2 days, I've not really heard anyone mention much about standards. So in the Indian Air Force, have you been following any HL7 or IHE profiles any of those standards?
I beg your pardon, could you repeat?
Have you been, in your software, have you been following any HL7 standards or IHE profiles or any of those standards that have been followed across Europe and America?
The standards we are following are basically standards that have been developed by the Air Force per se, and these are as per these worldwide standards adopted.
All right, thank you.
Excuse me, may I kind of add some inputs onto standards? As you were asking the question, one of the persons who has really pushed for standards in this country, Mr. Harinarayan, the head of the IRDA, just entered the room. So all of you please give him a warm welcome. But also to add to that, I think it's a very significant point because as each one of us are trying to grow our own IT systems and also work on connectivity, the single most powerful methodology for linkage is the creation of common standards. Now, standards get modified into multiple categories. There's location standards, there's individual standards, there's medical terminology standards. You'll also all be very happy to know that there is a standards format initial framework done which was validated by the Ministry of IT and the Ministry of Health. This is available on the website under the title of Health Unite. And Mr. Bedi, who was supposed to be here from the Ministry of IT, got held up, but this work is available. Subsequent to that, two important working groups have been created. One under the leadership of the Health Ministry, and Mr. Gaur is working on that. There's also a very important subgroup of the IRDA, which is working on billing formats so that there's an administrative standardization and makes work for each hospital easier. And as all of you know, insurance is driving multiple new changes in the healthcare sector. So that role of the IRDA is extremely powerful and significant, and that's why I mentioned that Mr. Harinarayan is significantly driving standards from the IRDA. Thank you.
Thank you so much, sir. Thank you so much, ma'am. And now I'd like to invite Mr. Arun Rai from Georgia State University to please come onto the dais and present the dignitaries, including our chairperson, with the mementos. Ladies and gentlemen, let's give him a huge round of applause and welcome him. Thank you so much, sir. Thank you all the dignitaries for a wonderful session.